Okay, hello everybody, and welcome to our sixth episode of the Community Health and Capital podcast, a podcast series supporting the 19 Hills Wellbeing Centre in Newport. I've got today with me Dr. Matthew Harris. Hi, Matt.
Hi, Johnny. Nice to see you. How are you?
Good, thank you, Matt. Thanks for joining. Matt's a clinical senior lecturer in public health at Imperial. I think we've spoken on and off many times over the years, often around community health workers, which I'm afraid you're going to have to stave your interest for a few weeks until a forthcoming podcast with one of Matt's colleagues in London. But Matt, do you want to tell us a little bit about your background?
Thanks, Johnny, and thank you very much for the opportunity to speak today. It's fantastic the work you're doing. So my background is in public health predominantly. I'm a consultant in public health medicine in the NHS with an honorary contract with Imperial College NHS Trust. My main role, though, is as a clinical senior lecturer in public health medicine within Imperial College London, the university. In that role, I'm director of postgraduate taught programs in the School of Public Health. So we have several master's programs which I oversee and help run. And I'm also the theme lead for innovation and evaluation within our NIHR funded applied research collaborative, which is a really important piece of work within Northwest London, linking together the trusts and primary care networks and other provider organizations, local authorities into Imperial College so that we can make sure that the research we do is as meaningful and as applied as possible. So within that, my theme looks predominantly at innovation, and that to that end, it's all about how can we support the evaluation and scaling and sustaining of innovations within the NHS, but also particularly learning from low-income countries around frugal healthcare solutions that they've developed and that we could use in our context as well.
Thank you, Matt. It sounds like a very busy schedule, so we're very privileged and lucky to have you with us here this morning. So I suppose just a little bit about the centre, Matt. So the centre is going to be in Newport. It's going to cover a population of about 16,000, lots of different NHS and community services, including from the council going in. And the principles I think we're trying to kind of push is a model that kind of promotes collaboration and integration of services, delivering more of a social model of health and well-being that really prioritises a lot more prevention, and something not always too strong at in the NHS, community involvement, patient participation, which we know there are a wealth of examples around the world that some places may be doing some of these things better than we do. In the NHS, we don't always talk a lot about health challenges overseas, and I think partnership working has still got a long way to go when it comes to collaborating with colleagues in low and middle income countries. You did, I think, yourself quite a bit of international work quite early in your career. Just wonder if you could tell us a little bit about that.
Yeah, absolutely. And I think it's spot on that you're looking at this space, actually, Johnny. I think there's so much that we can learn from international working, and there's so many benefits that it brings, not just to the individual that does work overseas, but also to the system if we provide the time and space to allow it to happen. So you're absolutely right. In the early part of my career, so I qualified in medicine, crikey, 25 years ago or so now. It's difficult to believe, but very, very soon after that, then went and worked in Brazil, in the northeast of Brazil. I re-qualified in medicine there, which is a bit unusual to have done that, but nevertheless, that happened. And I went and worked as a general practitioner in their primary care system for several years. I did a postgraduate qualification in primary care there as well. Learned the language, lived and worked essentially as a Brazilian GP. Then I returned to the UK in 2003, did my master's in public health at the London School of Hygiene, Tropical Medicine, before then working in Ethiopia and also Mozambique. So in Ethiopia, I was working with the World Health Organization on immunization programs, supporting the government, regional and central government around improved delivery of vaccination programs, including mop-up campaigns for sort of polio and measles and other important immunizations in very remote rural areas there. And then in Mozambique, I was running an HIV day hospital in central Mozambique in a town called Chimoio, which was a regional center for about 1 million inhabitants in central Mozambique in Manicaland province. where my role there was all about how to improve access to HIV diagnostics and monitoring and treatment, particularly highly active antiretroviral therapy, which was beginning to be rolled out through PEPFAR programming and USAID support. So that was a very much public health role as well. So, thinking about decentralizing healthcare, pushing expertise, diagnostics and monitoring expertise out into primary care level from the centre, because of course it was a context that had probably 25-30% prevalence of HIV. You can't treat that in a vertical fashion. You have to view that like it's as common as the common cold type thing, or diabetes. So that very much sort of moved me into sort of public health roles. So from primary care to public health, and I, for many years then realised that two things. Firstly, just how important primary care is for public health, but also just how much there is that we can learn from low-income countries. I witnessed, dozens of incredible, not just incredible expertise in terms of clinical acumen, but also ingenuity in terms of the way they deliver healthcare with minimal resources. And that really actually shaped, whilst it was the early part of my career, it really shaped my sort of career-long interest in understanding how to bring into the NHS innovations, low-cost solutions that have originated from or been developed in low-income settings. Because at the end of the day, we need to think of ourselves as a resource-poor context, actually. It certainly wouldn't hurt to think of ourselves as a resource-poor context. And where we can not only find opportunities to employ high-value but low-cost solutions, where we can also think about learning from settings that we rarely pay attention to, has since then formed really the central part of my career. So working overseas has been a foundational for me, experience. I just happened to sort of fall into that early on in my career. But had I not experienced working in those sorts of settings, then I think I probably wouldn't have spent the rest of my career thinking deeply about how the NHS can benefit from international health partnerships.
Okay. And I suppose the work you describe there, Matt, is quite long term, isn't it, really? Do you think that remains so much the norm for, clinicians and practitioners going to these contexts overseas?
Well, it is. I mean, I think this learning agenda has a very sort of long-term aspect to it, because it's the translation of any sort of innovative practice from one setting to another is difficult anyway. And the received wisdom is that it can take on average 17 years for something that's working well in one setting to be translated into another. But it's even harder when you think about translating something from a low-income, low-resource setting, a low-income country, for example, into the NHS. There's an even harder layer to that, because it's something that we don't see very often. We don't see many examples of having happened, and I think there are still, unfortunately, quite a lot of entrenched reasons for that, which we can also get into. There is a short-term aspect to this, though, of course, which I think is that any individual clinician or manager or director from the NHS that's engaging in work overseas, particularly in low-income settings, will have a really short-term benefit from that, which is a personal one. It's this sort of the experience of working in challenging environments. Many parts of the NHS are challenging in and of themselves, of course, but the sort of settings I found myself in were extremely challenging. So you have this short-term benefit of learning, how to apply your knowledge without the sort of diagnostic capabilities. So there's this benefit of your clinical acumen as a clinician working in areas where you don't have ready access to diagnostics, you don't have ready access to X-rays or urine dipsticks even, or blood pressure monitoring, or certainly not MRI machines or ultrasound machines. So you have to really rely on your clinical acumen. So there's a really short-term benefit to working overseas in these settings. It really pushes you to the very limits of your capabilities clinically. I think also there's personal benefit in the short term as well, in terms of resilience,
Mm-hmm.
in terms of, working again under resource constraints, how to just simply cope with that. There's also a short-term benefit in terms of cultural competence, how to work with others where you might not speak the language, you might not, be familiar with the culture, but you're a guest in that culture, and you know, you obtain, I think, invaluable life lessons from
Mm-hmm.
that's those sorts of experiences that can be easily, I think, translated back into the NHS. So these are sort of soft skills, let's say,
Mm-hmm.
I think are in the very short term will be translated back into the NHS, because they'll improve you as a clinician, they'll improve you as a person, so to speak, as a human, and you'll carry with you from that the opportunity to sort of just interact better with your patients and the communities that they're in. The longer term challenge is how do you, though, take learning, like concrete learning. So, for example, an actual technology or whatever it might be that's being used in the low-income settings, and how to actually translate that into the NHS is far more complicated, because there can be, regulatory issues or commercial challenges, or, it's about changing culture and practices and other things. That is a much, much longer term view, and that can take really a long time to sort of, happen. And we can get into, if you like, examples where we've been working to sort of do that within the NHS, or opportunities where we can certainly develop, space for these technologies to be used in the NHS. But I think, working overseas, if anybody listening to this is thinking of doing that, I, wherever possible, really encourage it, because it really is, creates a learning both on a personal and professional level, and on a system level, that is really second to none.
Thanks, man. I can hear the many hopeful benefits you described there. I just wondered, how hard did you find it making that kind of first step to working abroad and going?
So it's a funny, well, it wasn't funny at the time, but looking back on it, it was kind of funny, because I actually sort of went over to Brazil with a, rather colonial, I'd say, attitude. I was sort of thinking, of course they would need an English trained doctor, trained in one of the most elite institutions. They must be, they'd welcome me with open arms. I'd just walk into a job. It should be no problem at all. And it was really naive. That was, and very rooted, I think, in deeply Western sort of perspectives. I mean, the context where I landed was deeply impoverished. It was had no sanitation and no electricity, and people were living largely in mud huts, or on top of landfill sites. It was an extremely challenging environment, a very rudimentary primary healthcare system. But the regulatory environment of the medical profession was no less stringent and no less robust than it is here in the UK. So whilst I wasn't aware of it, I had to, in order to work as a GP in Brazil, I had to requalify in medicine, and rightly so. I had to learn Portuguese, and I had to pass exams in Portuguese. I had to pass exams in all the key clinical disciplines: obstetrics, gynecology, infectious diseases, clinical medicine, surgery, pediatrics, even forensics. I had to pass exams in, and rightly so, because actually all of this knowledge was important. They do things slightly differently. The medical terminology is slightly different. The language obviously is different. The medicines are different. The diseases are different. So one of the key things I had to learn straight away was actually, if I'm going to work in, I wasn't working in as part of some sort of wider international entity like WHO or Médecins Sans Frontières or some other international NGO, where you can sort of circumvent, in a way, some of these requirements. I literally had to, become a Brazilian GP, and it was that actually, I think, was the making of of the perspective that I then eventually had, because you can very easily sort of parachute in as part of an international entity, but that's a very different lens that you're going to see the work that you then end up doing through. When I worked in Brazil, as I said, had to become a Brazilian GP, and so you immediately get a different sense of the system. You're part of the system. You're paid like other people that are working that system. You understand it better. You're seeing it as a local, not as a foreigner, and you can therefore understand it better. It also meant, therefore, that when I returned to the UK, I could also see much more clearly how much we could learn from what was going on in Brazil. And we can talk about the opportunity. Well, you'll talk to Connie Jungens as well about this later on in another podcast about the community health worker model that they have in Brazil. That was a, you know, without sort of without having become a local practitioner in the way that I did, I probably wouldn't have seen the extraordinary potential of community health workers that they have in Brazil and how much we could benefit from them here in the UK. Subject for another podcast, but I think that was one of the significant challenges I had, but thankfully overcame and really was foundational for the rest of my career as a result.
And it's really taken off, hasn't it? As we'll touch on in a couple of podcasts' time, the innovative approach to the community health workers. But before we come back to that kind of frugal innovation, and diffusion of knowledge and ideas back, it's interesting you talk about the kind of the mindset of colonial attitude to kind of very unilaterally going out, presuming that we have a lot to bring. I suppose really, I just wondered, do you think the partnership model kind of is therefore the more suitable replacement? But I suppose a partnership model doesn't necessarily assume one or a body of people going out for longer periods. And what benefits do you think we can see then if people aren't necessarily spending such long periods overseas in that context?
Yeah, absolutely. So the experience I had in Brazil was not a partnership model, right? It was me going out as a lone worker. It's very different. So I think the partnership model absolutely has the potential to really co-produce, co-develop, really beautifully balanced partnership between NHS institutions and their equivalent counterparts in other settings. It really depends on how one goes about it, though, I think. I think there are partnerships and then there are partnerships. So, we see partnerships, for example, that still, I think, fair to say, rooted in a desire to translate knowledge and expertise from our country into another country. And it's easy to see why that's important. And there are obviously going to still be clear benefits to doing so because there is a need, right, to a large extent. And maybe we have technologies or expertise or capabilities or techniques, and there's merit in sharing that knowledge with our counterparts or colleagues in low-income countries where there may be a clear demand for that as well. Where I think partnerships, though, have the opportunity is if you also were to balance that approach by saying and going into it with a mindset right from the beginning that actually we also have a lot to learn here in the NHS from what is happening in low-income countries. It's not inevitable, but we should at least begin by being open to that. It creates a far more level playing field, I think, philosophically, around the partnership model. And sometimes it's easy to forget the importance of that. We've done a little bit of research, for example, that's looked at international health partnerships. This was a piece we published, I think it was 2015 in Globalization of Health, where we surveyed some partnerships that were being funded by the Tropical Health Education Trust with whom we partnered for this piece of work, just to ask, of the people that are engaged in those partnerships, what's been brought back, right? What technologies or ideas or ingenious solutions have actually, as a result of the partnerships, actually been brought back into the UK. And whilst a lot of people reported that they'd seen and witnessed some ingenious clinical solutions in the low-income country context, there was very little or very few examples of that being translated back into the NHS. So it wasn't that there wasn't the possibility of the learning, it just somehow wasn't materializing. And some of the reasons for that was that the volunteer or the person that was engaged in that partnership work really struggled to get their voices heard about that ingenious work that they witnessed, or that new clinical pathway, or that new solution, or that new technology. They maybe moved on to a different trust by that point, and so therefore when they returned, that learning was no longer part of that partnership. That there wasn't enough debriefing, for example, with the senior management of the trust where they work, or whichever clinical organization, in order to really build on the learning from that partnership work. And so, this comes really down to, I think, also, how do you capitalize on, for want of a better word, some of those experiences? They shouldn't just sort of disappear into the ether. They need to actually be made meaningful on return into the NHS, so that we can actually really benefit from, and actually demonstrably benefit from, a partnership model that is equitable in terms of learning. I had a PhD student a few years ago called Hamdi Issa, who's now actually the Director of Community Services at the Ministry of Health in Somaliland, from where she originated. And she did her PhD looking at international health partnerships. And she noticed something really interesting about some of the narratives in use in partnerships, something particularly around learning and reciprocity. And she noticed that there are two different types of learning that can take place. One she called technical learning, which is how do you do something type thing, really technical, the technical aspects. And then cultural learning which is more about your own self, learning about a context. And what she found was that actually what tended to happen, and her case study was actually with the Norwegian Health Partnership, not in the UK, but I think it still resonates. What was there was definitely a lot of technical learning from the low-income country partner's point of view, and there was a lot of cultural learning from the high-income country partner point of view. So it's as if to say, we learned a lot about Rwanda. We learned a lot, about that country. We learned a lot about ourselves working in that country, but very little. We learned a lot from the people in that country. Whereas it was always the case that the Rwanda, let's call it Rwanda colleagues, learned a lot from their Norwegian counterparts, in addition to all the other things. So the technical learning seemed to be absent in her research when it came to the high-income country partners within the partnership. And that's the piece that I think we really need to focus on, because there is a lot we can learn from our colleagues in low-income countries. Nigel Crisp talked a lot about the mutual benefit from international health partnerships, of course, in his book, Turning the World Upside Down, part 1 and part 2. And how much opportunity there is to co-develop innovations. Very frequently, we share similar challenges in our health systems. We sometimes just, we see the lack of infrastructure at times in the context that we might be volunteering in, and presume that there's nothing that we can co-develop together. But that really isn't the case. There's an awful lot that we can do.
An interesting disparity there. As you say, there's obviously so much technical learning to bring back. We'll leave it unanswered whether there's any cultural learning we want to share from the UK to other countries, really. But it's probably not what we should get into today. Obviously, you mentioned before, Matt, that these experiences have hugely shaped your perspective and the work that you've done now. And I know that it came to light in the book. I think you published it late 2023, was it, about decolonizing healthcare innovation. Do you think these are things that need to be designed and done nationally, or what scope is there for a local setting to try to implement any of these? The Wellbeing Centre we're building, we very much hope that we can deploy new approaches and new technologies. We think there is a space for collaborations with the private sector, etc. But how could we bring that kind of international element to this too? Is that possible?
Yeah, absolutely possible. I mean, if you're in your centre looking to support staff to work in or with collaborators or colleagues in low-income settings, then the first question is to really go into that with a very the first thing is to actually ask, what problems do we have
Mm-hmm.
in our centre? And because there are many, you know, might have a nice shiny building
Mm-hmm.
and looks as if you're well resourced compared to what's happening in Ethiopia or Malawi or whichever, but you still have problems that they may be able to help you with, right? So problems around integration, problems around access to care, problems around, you know, insufficient appointments or waiting lists or health literacy or the digital divide, or, you know, there could be, you still have problems, right? And there will be solutions that they will have come up with that will resonate with the problems that you also have. They might not look as sophisticated or technologically superior or anything like that, but they will solve problems that you have. So the first thing to do is just be open-minded and reflexive about what are our challenges. You know, it can be anything: loneliness, difficulty detecting someone who's at risk of severe mental illness. There's community cohesion where you are. You know, there are problems, right? You just have to spend some time thinking about them, I think. And then when you go into that partnership, you offer that to the people that you're working with, your collaborators and your partners. You know, these are the problems we have. How have you solved those problems? You know,
Mm-hmm.
and it seems quite a simple question, but we just
Mm-hmm.
don't really oftentimes see partnerships
Mm-hmm.
are going into it with that level of openness and transparency about a request for support, actually.
Mm-hmm.
So I think there's definitely opportunities. I mean, the work that we've done, you mentioned the book, and thank you for that, called Decolonizing Healthcare Innovation, available in all good bookstores. It came out in August, September last year in 2023. Focuses a bit more on technologies
Mm-hmm.
as solutions. So what I mean by that is, you know, sort of widgets, gadgets, those sorts of things. Frugal ones. So what this means is ones that do more with less. So they cost less per unit compared to what we're doing in the UK, but without scrimping at all on quality, safety, effectiveness. You know, they deliver exactly, or if not better at times, clinical outcomes for the task for which that technology has been designed compared to what we're doing in the UK. They might not look as good, they might not have the same level of functionality or sophistication, but that doesn't matter if you're trying to deliver on a clinical outcome and it does that just as well at a fraction of the cost, so be it. So the book talks more about sort of secondary, tertiary care solutions,
Mm-hmm.
if I'm honest. You know, it's sort of more in the space of plastic surgery, neonatal medicine, obstetrics and gynecology, orthopedics, general surgery. So it may or may not, you know, provide examples that resonate with your audience, perhaps. But nevertheless, it's just a point of departure to help people begin to realize that actually these are really ingenious solutions that have originated from the countries I've looked at were Malawi, Uganda, Brazil, India, Bangladesh, to name a few, originated from those settings. So if you're involved in a partnership with any of those, you've just got to keep your eyes open, to be perfectly honest, and you'll stumble across these sorts of techniques or solutions that may not necessarily be used in your center, but could be appropriate for use in your wider clinical network, with its knock-on benefits as well.
And I suppose outside of a partnership, are there any places that there's any kind of marketplace or forum to exchange ideas being developed to to join these networks up more effectively at all and help that innovation spread?
Yeah, so it's a sort of slightly, there's a case by case basis to this as well, right? So each of the technologies that you might stumble on or discover or that we've talked about and published on, you know, will have its own, you know, interest groups and areas and networks that are trying to work in that space, right? So it's a little bit case by case basis. There are, however, a few platforms that are useful that you can go to as a resource. So, for example, the Centre for Health Market Innovation, CHMI, is a Gates-funded project. It's a platform through which ingenious solutions from all around the world, oftentimes and predominantly actually from low resource settings, get posted with varying degrees of information, technical information about those innovations, but nevertheless a very useful starting point to sort of see, well, what's working elsewhere elsewhere, and how can we maybe spot that and see whether it could work where we are as well. All right, so that's quite a useful resource. And there are literally thousands of examples in that website. The WHO also produces a compendium every year or every other year on technologies for low resource settings, by which they generally mean low income countries, which is also a very useful resource because they describe in quite good detail the benefits and disadvantages, the costs, the outcomes, the evidence base for each of those solutions. And again, they tend to be technologies, right? They tend to be, they're not systems of care. They tend to be gadgets, X-ray machines, frugal X-ray machines, frugal ultrasound machines, those sorts of things. So those are two really, really useful points of departure. Another one is exemplars in global health, which again, Gates funded. And they generally look at sort of country level policy analyses. So what's going on in Bangladesh, for example, that's worked really well around climate change mitigation strategies, or what's happening in Brazil around conditional cash transfer programs and how effective they are. It's really, again, useful case studies at more national level around exciting health policy innovation and what other countries could learn. Where there isn't much happening is actually the kind of work that I try to achieve in my book and all other publications my team have put out, which is taking those examples, taking those solutions. What does it mean for our context? How can we go one step further beyond just describing the benefits of those solutions to actually understand how might they be suitable for the UK context? What could be, if they're used, the potential benefits, both clinically, economically, and other things with that solution? And how can we think through what might be the issues in terms of the adoption of that in the UK in order to advance the conversation around that particular technology? It's one thing to see something in use in another country. It's another thing to really unpack what the implications of that technology's use might be in the UK context. And I think that's quite helpful exercise to do, because it means others can then begin to, in a sort of a scaffolding way, begin to sort of take that thinking and consider it more meaningfully in whichever setting they're in. Maybe pilot it, maybe think about doing a feasibility study with it, and then see how it goes from there. Nothing is really sort of adopted at scale overnight. You have to build up to it through that sort of iterative work.
And I just wondered, without ascribing any judgment to the pros and cons of this, do you see the private sector seeing a niche for bringing these innovations to a high-income country setting at all? I mean, we've seen a lot of kind of traditional medicines, I suppose, haven't we? Kind of being researched and kind of brought to market as kind of patented drugs. Is that something that's going along with health and tech innovation at all?
The role of the private sector, obviously, again, it depends on which technologies you're talking about a little bit, but it's an interesting one, because the sorts of technologies or solutions that I'm referring to tend to be things that are not patented or even available. So they are just workarounds that a clinician may have come up with, that just actually, when you look at it, works just as well as an actual patented device that we might pay thousands of pounds for each here in the NHS. I'll give you one very quick example of that, right? In obstetrics, postpartum hemorrhage is a terrible issue, leads to lots of maternal mortality. Not that much in the UK, perhaps, but certainly in resource poor settings, it's a huge problem. And we, in the instances that we have postpartum hemorrhage in the UK, we use balloon tamponade devices, each of which can cost £200, £300. They're essentially catheters with a balloon on the end that you inflate with saline and insert into the uterus, and it exerts pressure to stop the bleeding. Whereas in Bangladesh, you can achieve exactly the same outcome just by tying a condom to the end of a urinary catheter, both of which are readily available and very, very cheap. So you can, it's just an example of what the kind of solutions I'm talking about here. And the outcomes of both of those technologies in head-to-head trials have been identical. So why not just use a catheter, so to speak? The thing is, there's no commercial opportunity for that. There's no, the whole point of frugal innovation is really that it's about saving money, not earning profit. So, there might not be, in fact, there often isn't a commercial logic or rationale behind frugal innovations. It's an entirely different philosophy, if you like, to how we innovate in the UK. Innovation tends to be about developing a new technology, patenting it, and marketing it and selling it in order to make a profit and recoup your costs. This is all about something else. This is about how can the system save money by using resources that we've already got around us in an ingenious way that doesn't cost very much. And then in that savings money, you can redistribute the resource elsewhere by recruiting nurses or doing whatever else. So the private sector doesn't have a clear, it's case by case basis, of course, but there isn't a clear space for private sector involvement in this, unless it can be done through a sort of clever financial business model in partnership with the health system. So it can recoup costs, it can still earn money through that frugal innovation, but in a different sort of way. But we've often thought about it as, for example, top slicing the savings that the system may have accrued from using that technology, the frugal technology, top slice that as if profit, but you at least are still on balance potentially making savings in the system as a whole. So again, a very different kind of approach, I think, to the market-based profit-making sort of philosophy that we have with innovation.
Well, Matt, thank you. We've heard you talk about your personal experiences of global health and international work. We've talked about the kind of different approaches in a partnership model, and I think there's lots of ideas and food for thought around how we could bring in, not just kind of domestic innovation, but kind of innovation overseas into our wellbeing centre. Just as a final question to round off, where would you start if you were kind of exploring the kind of partnership work with a low income country?
I think the Tropical Health Education Trust is a really important resource to begin to look at, because they have a long history with working with through partnership models with low-income country partners, and can provide, I think, significant support for if you're beginning that journey of how to develop a partnership. They, with work that we've done with them, are very attuned, I think, into this idea of a much more reciprocal, mutually beneficial partnership way of working. It goes beyond sort of more traditional sort of delivery of services or even expertise going in one direction only model that we used to have, I think. So there'd be a really good place to start. And I know that they have lots of funding opportunities that come online frequently about how to support those partnerships. I think you probably need to think very carefully about which country you're looking to partner with and the reasons for that. Sometimes these are driven by individual sort of connections and networks, but also just whatever partner you land with, just be very clear from the outset, I think, about what you are looking to gain from that partnership work, that it should be a horizontal reciprocal benefit, that you don't go into that partnership with all the answers, but you also go into it with lots of questions and understanding your own problems and really asking how can they help you too in that partnership way of working. What solutions can you develop together for problems that we all have, for example? So it's not for me to say which country you should focus on, but maybe it is for me to say, if you do arrive at that, go into it with a really open mind, looking to learn as much as to teach.
Thank you, Matt. There's a lot of wisdom and practical suggestions there. Really, really grateful. Well, thank you everybody for listening to our 6th episode of the Community Health and Capital podcast today with Dr. Matt Harris from Imperial talking about global health partnerships and reverse innovation. We'll have another podcast out to you in a few weeks. If you've got ideas for episodes, please let us know. Any comments, get in touch. Thank you again, Matt, for joining. We're really grateful for your time.
Thank you. Let's start there.